Well, hello, and apologies we're a couple of minutes late. We had some technical problems. These things happen, unfortunately, but we're here now. So a very big hello from the University of Derby. It's beautiful weather outside, but unfortunately we're all stuck inside. My name is David Robertshaw, and I'm the academic lead for nursing and health and social care at the University of Derby online learning. For those of you who don't know me, my background is in nursing. And I'm the program leader for a couple of programs here which are delivered through online learning, two of which are based on dementia, which is why we're running this course. I'm also the lead academic for the MOOC that you've all been studying, and we're now in week 3. So we've had 3 weeks of some really interesting debate and discussion, and hopefully this week I can answer some of the questions that have been raised on the forum. And we'll talk a little bit about next week as well. So last week's webinar, I was joined by Yesu and Ian. We talked about all sorts of different things, mostly around compassion, and it was really great to have them here. It's just myself this week, and next week it'll be just Ian Welsh, who is the other person who's working in support of this course. So, and Ian's going to be talking about different issues, obviously, to the ones I'm talking about this week. So this week we've been looking at independence, control, and quality of life, and it's been quite a challenging week, really. We've looked at some quite advanced concepts, including law and ethics and all sorts of things. So, but the main underpinning principle, really, which I'd urge you to consider, is about dignity. So, if anybody is held in prison, for example, or is unable to express their full freedom, then we need to make sure that that person still has their dignity. And often, being in hospital is not like being in prison. You are free to leave, but often against medical advice, for example, or you're held there for some reason, you have to be there for treatment, and maintaining that dignity for somebody whilst they're in your care and in your charge, as it were, is incredibly important. We've seen some really high-profile cases, actually, where dignity has been missing in care, and that really underpins much of what we've been talking about this week. And specifically in the UK, we've had the Mid Staffordshire, the massive thing about the Francis report from the Mid Staffs, and how dignity was really lacking, and people didn't receive basic things such as water and food, and water had to be prescribed, for instance, just so that people can have some. So, and there are obviously many other examples, unfortunately, where care has been substandard, and actually dignity has not been maintained. And things like the Winterbourne care homes, and there are other examples as well. So that really sort of has been a driver for improved care as dignity, and dignity is closely related to the 6 C's that we talked about in previous weeks as well. So this concept of person-centered care we've been talking about this week, and really this is to do with putting the person at the very center of everything you do. So a service, whether that's probation service or an NHS trust, an emergency department, or whatever, a GP service, rather than being centric around the people who operate that service. So often in the past, for example, hospitals in the past had car parking spaces, and the car parking spaces at the very front near the door were often reserved for the consultants, the people who were considered the high and mighty, that people could make feel better, and they were amazing personalities, and but actually that was wrong. They can walk. They should be able to park somewhere in a staff car park somewhere. So what the hospitals did was they decided that those spaces would go to the people who most needed them. And they were people who were visiting the hospitals, who had additional needs, who perhaps had mobility issues, that kind of thing, or needed to get in quickly. So, do drop-offs and things for emergency departments. So we had a bit of a change in the system there. And what that did was it centered the parking, in that case, around the person. Now, obviously, that's a very sort of basic example, but we can look at entire service reconfigurations to make sure that the patient or client or service user's journey is based around them and is the smoothest and most easily followed as possible route. So, person-centered care based on a few principles, and we talked about the VIPs principle, which is V, a values-based that asserts the absolute value of all human lives, regardless of age or cognitive ability. I, an individualized approach recognizing uniqueness. P, which was the perspective of the service user. And S, providing a social environment, the S is for social, that supports psychological needs. So really it's much more than just building a service. It's looking at it from the perspective of that person and embedding values in an approach and looking at their perspective from an environmental but also an individual one. So that really, why are we talking about person-centered care? Well, often the people who have dementia in the past have not experienced person-centered care. So what we need to do is put them at the very center of everything that we do and every service that we provide to make sure that what they need is what they get. So that means the GP giving them appointments on time, for instance, giving them the referral pathways that they need to be able to go see the consultant or the physio or whoever when they need it. So we also talked about the ethics and law, and we talked about the two perspectives. We talked about utilitarianism and deontology. And of course, utilitarianism is the view that only the morally relevant features of an act are its foreseeable consequences. So basically, whatever the choice of actions are, the morally correct one is the one that we should do, and it's the best one for all concerned. And deontology is more looking at the moral duties or moral rules rather than actually looking at the consequences of the action. So that the perspective there is that the correct act is the one that's right in itself. And so I guess we heard from Bill Whitehead, who's the head of nursing at the University of Derby, and he talked about the scenario where a nurse has an NMC code, which is their code of conduct, what they should do, what they shouldn't do, and it talks about that. He talks about, should you do the right thing or should you do what it says in your code? Well, if somebody is suffering but your code says don't intervene, well, you might still intervene, and actually there will be circumstances where you may go against the NMC code, and I'm not advocating that you do that in any circumstance. But I think the example he gave was in Nazi Germany in the Second World War, and how nurses, and health professionals in general, did pretty terrible things, and they were considered right at the time because that was what was going on in that environment. It doesn't necessarily make sure that they're a right thing to do compared to everybody else. So I found a really nice quote which I thought I'd share with you, which is G.K. Chesterton, who said that right is right even if nobody does it, and wrong is wrong even if everybody is wrong about it. So that kind of relates to that, really. If the right thing is right, then even it's still right even if nobody does it. But the wrong thing, even if people are wrongly doing it, it still makes it a wrong thing. So quite a powerful quote, really. And the activity we looked at this week was is telling a lie wrong? And actually, there were some absolutely fantastic answers to this. And what we really I've discovered, and that you've discovered too, is that this is actually a really complex question to ask. And lots of you who are nurses and healthcare professionals have said that you should act with honesty and integrity, and that's part of the NMC code, and therefore telling a lie is always wrong, always wrong. But some of you quite rightly said, well, what about some people that if you told them the truth, it would devastate them? And in the first week, we saw a video of a lady who found out that her husband had died. And I'm not suggesting for 1 minute that you would tell her that her husband was alive, but her daughter told her that her husband had died, and she had to go through that every day, finding out that she had lost her husband, which is obviously a very sad thing for her to go through. Now, would you ever, in that circumstance, tell them a lie? And I'm not sure personally whether I would always tell the truth in those kinds of circumstances. But I guess you have to do what's right at that time. Now, I'm not suggesting for 1 minute that you should go and lie about things, and I'm certainly a big believer in telling the truth and being honest about things, and keeping your integrity intact. And that's quite a strong foundation of mine as a nurse, and I'm sure it is of many other people who are nurses too. And lots of you said actually that as children you were taught and told and almost grew up knowing this, that you should never lie. And somebody said that philosophy had followed them throughout their entire life, which is quite a powerful thing, really. So it's interesting that it's sort of a bedrock of our communities and of our social landscape, is that you should really, in honesty, tell the truth. So a couple of examples that people have shared, and this was Becca DeVille, said, we haven't told my grandmother that she's outlived all but one of her 3 children, as it would cause her so much upset. She tells everyone that her deceased children come and visit her. Why would you tell her the truth when it's so potentially devastating? She wouldn't remember what you told her for long, so you would have to keep telling her, morally thinking she should be told, because you will be acting with honesty, but it wouldn't be in her best interests. So thank you very much for sharing that, Becca. And I think that's kind of what we're a good example, really. What we're trying to understand is if you kept telling her the truth, would it be so devastating to her that it may not be in her best interests to keep doing that. Mary Jackson said that telling lies has always been the wrong thing to do, but if it saves a life or prevents a problem then I feel it's justified. Being honest can cause so much upset to someone with dementia, especially if you keep retelling someone an upsetting fact like their partner may no longer be with us. Sometimes it's best to go with what they may believe, either at the shops or at work. There is a fine line with every decision we make, and I think that's Mary's saying the same thing really as Becca, that actually it's perhaps not always right to go with that person. It's interesting, when I first did my nurse training, I was told very clearly that if somebody is delirious or hallucinating or perhaps doesn't have that insight, that you should always ground them and bring them back to reality and tell them the truth. You should always do that. But as I've qualified and worked with people, I think that I've obviously seen many examples and scenarios of where that's not worked so well, and some when it has worked very well. That actually, reorienting people has been a really important thing. So I guess there is no answer to this, which is why we've been discussing it. But it's as Mary said, it's a fine line with every decision we make. So that kind of leads us on nicely to the next part that I was going to talk about, which is about the 4 principles. So the 4 principles which we looked at, which are beneficence, non-maleficence, autonomy, and justice, really help us to make decisions like this. So that they're used for decision making and with an ethical background, and actually no one of them is more important than the others. We had a discussion with Bill Whiter this week in one of the videos about, is autonomy more valuable than the other ones, but I think that the originators of these principles will probably argue that all 4 were equal. But they can really help us to make a decision. So beneficence is doing the best thing for the person. Non-maleficence is not doing a bad thing or not harming them. Autonomy is maintain they have their independence. And justice is doing the right thing. So we could use these principles to make a decision, lie, or should we tell them the truth? And actually, healthcare professionals do use them quite a lot. Whether they use them explicitly or implied, it's probably not entirely clear, but they are used quite widely. So consent, we also talked about this week, and just a reminder that this only is consent within the UK, specifically England and Wales, but the principles are broadly the same. Consent is somebody saying that yes, you can do something to them, whether that's give them an injection or take their blood pressure or undergo major surgery, for instance. We have to get consent for all of those things. And the reason this is in here is because people who have dementia often are not always able to give consent, and consent really relies on that the person can receive enough information, that they can have the cognitive and emotional capacity to be able to understand the nature of a treatment or whatever it is, that they can understand and comprehend what they've been told, and then also that they can return their decision to you. That they can make their decision independently and free from any coercion or interference. So people with dementia often are unable to, especially at the later stages, may not be able to understand fully the reasons for a particular procedure, or they may not be able to express their choice and their outcome. Now, we know that express or implied there is an express or an implied consent, and the implied consent is you go to somebody to take their blood pressure and they put their arm up, and that's an implied consent. I'm rather than saying yes, please do take our blood pressure, I give you consent to do this, they simply put their arm up. Now, express consent is when you would specifically sign a consent form, and which one you choose, it obviously depends on the nature of the procedure. So if you are going to do an appendectomy, for instance, you wouldn't do implied consent. You would have to make sure that the form was signed. But if you were taking someone's blood pressure, then implied consent would be fine. Now, what we do know is that often people with dementia have varying levels, and we can call these islands of lucidity. So when particular periods in time when they can return to near normal function in terms of cognition, and then in those examples, they are able to make a choice and a decision. So what we should do is we should try and hold off any decisions until such a time when people can make an informed choice, and we should always support people to do that. So we had quite a short discussion really about a new drug that had been developed, which was very expensive but could extend the life of somebody by 2 weeks. But the cost of it was such that it meant that people couldn't have other things. And it's quite interesting that most of you took a utilitarian perspective. But very interestingly, some of you said that you couldn't really make a decision as there were too many unknown variables. And it wasn't really a fair question, that it was possibly loaded in one way or another. But I guess this kind of question is quite a common one, and more so in the cancer drugs field. When a new therapy perhaps will gain somebody a couple of months with their family, but they obviously they may be able to retain a normal cognitive function and be able to enjoy that time with their family. Like a postcode lottery, for instance, people live in certain areas, their trusts, their environment, their clinical commissioning groups are able to pay for certain drugs, therapies that you may not do, for instance, across the wall in another postcode. So that's quite a common thing. And what I've tried to do here is to encourage you to discuss. And Tim Benson's, I'll just share with you Tim Benson's response. He said the answer seems glaringly obvious. But be careful of the way that the information is being put. Yes, this is an exercise. 2 weeks doesn't sound like much until it's my 2 weeks or your 2 weeks, then it seems an eternity. Provokes a good discussion in the light of an informed debate. Do we stand any chance of having that kind of public debate when we have such a sensationalist press? Personal and professional decisions are difficult. Also, as you often do not have all the information, in any case, whose information is it? So Tim's really touched on a number of points here, and the role and involvement of the press, particularly in the funding cases, has been quite a powerful one, actually, and not always one in a positive way, I need to say, I guess. So thank you very much for your contributions to that, especially Tim, who I've shared. So before I sort of come to an end, I've got a couple of questions from Marina, who had some quite specific questions. So one of them was about levetiracetam. It's also known as Keppra. So this is a drug which is an anti-epileptic medication, and I'll try and answer these in as common language as possible, really. Marina said, I'd like to know about levetiracetam and why some people suffering from dementia are required to take it without having any epileptic crisis. Why doctors can't stop patients from taking this medicine because of its side effects. Some patients have awful results regarding their health. Thank you in advance. So what I would say is a forum or even this webinar is no substitute for the advice of your doctor. And I would, if you have a serious concern about something like this with someone that either yourself or somebody that you know, always go and speak to your GP, your family health provider, and discuss it with them. And obviously I can't give you health advice, but what I can do is give the group in general some general advice about levetiracetam. So levetiracetam is, or Keppra, I'll call it Keppra, that's the name I know it by mostly, is used for epilepsy, and it's available in tablets and IV drugs as well, intravenous drugs. So that's drugs that go into the vein. Now, at first glance, you'd think, why are we using it for this? And I have to say, I probably agree. But there has been some evidence, small trials, with crossovers, so they're often very difficult to actually understand, with sort of 50 or 60 people. So again, in terms of generalizing, it's very difficult to do. And these are people who had mild cognitive impairment and who were at risk of having Alzheimer's or developing Alzheimer's, but didn't actually have Alzheimer's at that time. And they conducted memory tests and looked at what sort of activity is going on in the brain. So some of these previous studies have showed that people with mild cognitive impairment have overactivity in a particular part of the brain, and that's called the hippocampus, during a memory test. Now, Keppra, levetiracetam's drug, has been shown in some animal research studies to reduce the activity, reduce particular activity in this part of the brain. So what they did was, again, in these very small studies, and so I would caution the evidence is quite limited, was that they found that overactivity and performance, so overactivity was improved, the performance was better after taking this drug with a placebo. So that's that's some of the evidence around the drug. But what my advice to Marina would really be is go discuss it with somebody that's near you, or able, if you've got a serious concern about this, it's worth having a conversation about it. Marina's second question was about DSM-5, and so I'll talk about DSM-5 in a moment, but how dementia has changed the terms and changed the names to be neurocognitive disorders, mild, severe, etc. And so I'll read a question. It was another crucial question from Mr. Shaw is why dementia has been removed from DSM-5 and how he finds it, as they now call it, neurocognitive disorders, mild, severe, etc. ICD is a more precise description, in my opinion. And neurologists sometimes are excessive, which doesn't help people with dementia. Would you give us some more details on that? I think they have some extreme opinions. For example, in an institution of people with Alzheimer's disease and dementia, they prefer neurologists instead of psychiatrists, who could collaborate better with a psychologist, though, common language required. So DSM is the Diagnostic and Statistical Manual for mental disorders, and this is basically a book. It's a really big book, and it's used for classification and diagnostics. Really, it's a tool that affects diagnosis, treatment recommendations, and actually, if you're in the United States, it can even affect insurance and reimbursement and that kind of thing. So it's quite a well-used book. We're on DSM-5, which is the 5th edition. ICD we mentioned in there is an international classification of diseases, I think, and that's a very similar system, but that's produced by the World Health Organization, who are sort of a global body who look at public health. And that is a more general medical classification list. So DSM specifically looks at mental health, and ICD is everything else and everything. Now, the DSM-5 removed the term dementia from it, and it replaced it with major neurocognitive disorder and mild neurocognitive disorder. So, okay, why have they done this? That's the question, I guess. And what I would say, though, is even though the terms are different and they're not necessarily interchangeable, which is an interesting thing to say, is that actually they'll have how the term dementia is used out in the wider world, at least at the moment. And because what people with dementia or with mild or major neurocognitive disorders will experience are still the same things. And hopefully that's a person-centered care and sort of an abilities-based approach. So actually the actual end user should receive nothing different. But I think the main reason this has changed is probably to do with stigma. There is a lot of stigma around the term dementia, and the origins of the word are to do with, probably not really to do with what the disease is, the syndrome is now in our modern world. So actually, it probably is a reflection of just the changing times and the changing climate of language and language use in health, really. But what I would say is there's lots of great information on the World Health Organization website if you want to know more about ICD and what's going on. So hopefully that answers your question then, Marina. And if it doesn't, then feel free to send me a direct message and hopefully we can continue that dialogue. So next week, we're going to be talking about dementia as a global health priority. and we're going to talk about what's going on in other countries and look at national dementia strategies and all sorts of things. And Ian Welsh will be leading the webinars from next week. Ian is a great colleague, and he's worked in all sorts of different environments, so I'm sure he'll have a lot to share with you. And we may even have a special guest, which will be a nice thing. So just two last things to say. Remember to get your badge for this week. Again, we know that some people are having issues with badges, so we're still working on it. I apologize about that. And if you are having issues, please feel free to send us direct messages, send us an email, or let us know on the help forums, and we'll try and be as helpful as we can be. The team here really want to make sure that you can get your badges, so let us know. To get your badge this week, you need to have read all of the unit pages and also participate in the Is the Telling a Lie Wrong discussion board, and then it should pick it up automatically. The last thing to tell you is the hashtag, which is the hashtag Dementia MOOC on Twitter. We're using that as a bit of a tracker if you want to send any comments, questions. I had some discussions last week with one of the learners, and that was really great. So please do feel free to get in touch with us any one of those ways. Right, and that concludes this week's webinar. And thanks for coming, and thanks for watching. And I hope you have a great weekend wherever you are in the world. And yeah, so we'll see you next week.